Did you know that there is a neurological disease in which your own body's immune system will attack your own brain? Why would it do that? It's a disease that you've probably heard of. It's called multiple sclerosis, or MS for short. A 36-year-old woman came to my office with complaints of numbness and tingling in her hands that's been going on for months, but has gotten worse over the past several weeks. She was even having trouble with her balance, so she thought she should get it checked out. When we saw her in the office, she has had no imaging studies, so we did a detailed history and physical examination, including testing of her reflexes. When your doctor bangs on your knee and you see if you can kick them. And if your knee kicks out too strongly, it can actually be a sign of spinal cord damage or spinal cord compression. There's a real reason why we do that in the doctor's office. It's a way of testing the spinal cord's function. Or shall I say, detecting any dysfunction. There are reflex arcs in our body that help us detect if there's any problems with our nerves in our body. It's one of those components of the physical examination that is extremely important for a spine surgeon. I can't tell you how many times I've picked up a diagnosis that another physician has missed because I check the reflexes. In fact, it probably happens at least once a week. Numbness and tingling in someone's hand could lead to many different diagnoses, and one of the tests that I did is something called the Phelan's test, where you'll have someone hold their hand down like this and press it in this position, and if that makes the numbness and tingling worse, it can be a sign of something called carpal tunnel syndrome, where your median nerve in your wrist can get impinged and lead to numbness and tingling in her hands. But on physical examination on her, this didn't make it any worse. And when I saw that she had brisk reflexes, I was really concerned about something in her neck. Numbness and tingling in the hands, balance troubles, and hyperreflexia are all concerning signs of something going on in the spinal cord and the cervical spine. So we promptly imaged her cervical spine, and this is what it showed. This gray tube right here that runs up and down is the spinal cord that runs through the center of the spine. It typically is this darker gray color, but there's several spots throughout the spinal cord on this MRI that are giving us some wider signal, which is a potential sign of something going on inside of the spinal cord. In other words, these patchy white things in the middle of the spinal cord is usually something concerning. Usually three things that come to mind. One is spinal cord compression, or where you'll have a bulging disc that is pinching on the nerves and the white stuff in the spinal cord is actually swelling. But we can see on this MRI, there is absolutely no compression. This white is spinal fluid, and all the way up and down her spine, there is no sign that the spinal cord is being pinched. The second thing that I'm worried about is something inside of the spinal cord, like a spinal cord tumor. But the reason why I really don't think that's the case here is we did an MRI with contrast. It did not enhance, but not only that, is that the spinal cord is not swollen. In other words, the caliber or the size of the spinal cord in a tumor will usually be wider than normal because there is the spinal cord plus a mass which expands it or makes it wider. And here up and down you can see that the caliber of the spinal cord is the same. So that makes me concerned about something called demyelination. This patient has a diagnosis of multiple sclerosis, an autoimmune disease where your body's immune system will attack the coating on the nerves inside of our brain and spinal cord. The nerves in our body are relaying electricity, and they have something on them called a myelin sheath. This yellow stuff right here, and think of it as like a coating on the nerve itself. You know how electrical cables will have a sheath or a plastic coating on it? Think of the nerves and the myelin sheath as something very similar to that. You all know that if you have a live wire like this, the electricity won't get delivered the same. Demyelination of the nerves in our body will cause exactly the same thing, where you will have basically a live wire in your nerve and the conduction does not happen normally. Here you can see what a normal myelin sheath looks like, and here is something what happens in multiple sclerosis, where the sheath or that myelin coating will get disrupted. And because it can affect any nerve in our body, two patients that have a diagnosis of multiple sclerosis may not even have remotely similar symptoms. There's a 3-to-1 prevalence of women to men, and it's usually diagnosed in the 30s and 40s. So you can think of a lot of times when a 30-year-old woman comes in to the doctor complaining of all these weird symptoms, you know what happens. Let's just say that a lot of times the diagnosis gets overlooked. And a lot of times, if you think that the doctor doesn't believe you, why would you want to go back to the doctor with the same complaints? Needless to say that sometimes the disease can progress along and the patient does not yet have a diagnosis. Multiple sclerosis is actually the second most common reason for neurological impairment in young adults, secondary to a traumatic injury. Now, I did mention that in our patient, she had a temporary period of time where she seemingly had loss of vision for a few weeks that got better on its own. And I mention that because she likely had a diagnosis of something called optic neuritis, which is inflammation in the optic nerve that happens as the presenting symptom in 15 to 20% of patients that have MS. And in fact, around half the people that have multiple sclerosis will have an episode of optic neuritis at some point in their disease process. It usually affects one eye, and there's eye pain that is worsened by range of motion of the eye or moving your eye around and is associated with some form of vision loss. Because the optic nerve, or the nerve that relays the signal from vision to our brain, is inflamed and those signals are distorted, so you can't really see well out of that eye. Some people have complete resolution of their vision, and some people have ongoing permanent visual loss secondary to an episode of optic neuritis. That is one symptom of MS, but other symptoms include extreme fatigue, not just the I'm tired at the end of the day kind of fatigue, but an overwhelming sense of fatigue that you really don't feel like you can even get out of the bed. And depending on what nerves are affected, it can cause a wide range of other problems, including numbness or tingling, weakness in your body, tremors, pain, issues with going to the bathroom like incontinence, trouble with your bowels, and even trouble with memory and thinking. And again, reminder that these are all really non-specific symptoms. We don't really know why certain people will develop multiple sclerosis. If the diagnosis is suspected, we will often image the brain or spinal cord with an MRI scan. And what we can see is what I showed you on our patient's spinal cord MRI, but on this brain MRI, you can see those little patches of white things on the brain, which are signs of demyelination, or where the nerves in the brain have lost their coating. We'll also usually sample the spinal fluid to evaluate and see if there is anything inflammatory within the spinal fluid that would indicate demyelination. MS, we usually look for something particularly that are called oligoclonal bands. Oligoclonal bands are immunoglobulins that can be detected in the spinal fluid. The presence of these inside of the spinal fluid can be indicative of inflammation of the central nervous system. Other testing includes evoked potentials, blood testing, and even neuropsychological testing. And all of these things are usually done under the direction of a neurologist. And sometimes making that diagnosis is not easy. Let's make it even more confusing. There are 4 types of MS. Relapsing remitting is the most common type with about 85% of cases. That means you'll have episodes where you're clearly having problems, where you're getting worse, and then all of a sudden everything kind of smooths out. Second type is primary progressive, where symptoms slowly escalate over time without any sign of remission. Some people will develop the third type called secondary progressive MS, where you have relapsing and remitting, and then all of a sudden it transitions into a progressive development of symptoms without any sign of remission. The least common type is something called progressive relapsing MS. That's where you'll have steady progression of symptoms over time with some very small periods of relapsing. Have I confused you yet? Early diagnosis and intervention is critical to help reduce disability over time. Although there is no cure for MS, there are variable different treatment options that can help improve the quality of life and help manage the symptoms of MS. DMTs, or disease-modifying therapies, are medications that help reduce inflammation in the nervous system. Obviously, steroids can also be utilized because they also reduce inflammation in our body. And in some cases, we'll even use something called plasmapheresis. It's where you can actually remove the blood from the body, remove those harmful antibodies that are attacking the immune system, and then put the clean blood back in. These are the mainstays of the medical treatment, but there is so much more that goes into help managing these symptoms in these patients. It is so important for these patients to stay active, because physical inactivity can lead to worsening weakness, pain, immobility, stiffness, and the fatigue that comes along with all of that. Physical therapists and occupational therapists can be monumental in helping these patients along the way. Remember, these are young people that are diagnosed with a devastating disease, so mental health is really important, and depression is seen in a lot of patients with MS. Acknowledging that and treating that is really important. Now back to our patient. She had some active signs on her MRI of demyelination, and she underwent a spinal tap that helped us make the diagnosis. She was diagnosed with relapsing and remitting MS and was started on treatment. She was first started on steroids and then continued her treatment with a DMT. This helped significantly reduce the amount of numbness and tingling that she was having in her hands and the balance trouble. Now she has her diagnosis and a plan of action moving forward. Another case of patient-focused and compassionate care. Stay tuned next week and I'll go through another case.